Dear students, in this lecture we continue the description of the fine structure of the kidney. As you remember, on the previous lecture, you had the details on the fine structure of the Malpighian corpuscle, including the Bowman's capsule, the podocytes, and the mesangial cells, and the other details. The only thing that we have left is this beautiful group of tissues, which altogether we named the Juxtaglomerular apparatus. This group of tissues is extremely important in the medical practice, since these are the most powerful controllers of our blood pressure. If you become a medical doctor, almost 1/3 of your patients will suffer high blood pressure, and most of them, the cause starts in this area. So this is why we take very seriously on the exam if you don't know that. The Juxtaglomerular apparatus consists of 3 cells. One of them is the so-called macula densa. I talked about it before. These are specialized modified cells of the distal convoluted tubules, which are in contact with the vascular pole of the Malpighian corpuscle. Here you can see a realistic picture. So this, probably you recognize this as a Malpighian corpuscle. This is a distal tube, and those cells which are in contact become darker and larger. This is what we named the macula densa. This is located once again in distal tubule. This is about a group of 15 to 40 cells, not too many, and they are sitting on a fenestrated basement membrane, which is rare, but it suggests us that some control substances, relatively large molecular weight, should pass through it. On the top of the cells, we have microvilli, and we have lateral processes in which these cells will in contact with each other in a larger surface. The second components are the extraglomerular mesangial cells. Remember, briefly I talked about that. These are star-like cells, named stellate cells, and we have adrenergic nerve fibers between them. What is the function of the adrenergic nerve fibers? We really don't know, or just we have a guess. But it should be, but very probably they modify somehow this system. The third one, and maybe the most interesting component, are the juxtaglomerular cells. These juxtaglomerular cells are smooth muscle cells in the wall of the vas efferent, and they are modified. By the way, the smooth muscle cells have a remarkable complexity. They can do a lot of unexpected things. They can produce basement membrane. You remember there is basement membrane around every single smooth muscle cell. They can produce collagen fibers. So the collagen fibers in the smooth muscle is not produced by the fibroblast, but with the smooth muscle cells themselves. And among others, they can produce hormones. These cells, smooth muscle cells, have vesicles in the cytoplasm, and they produce a hormone, what we name the renin. Renin is the first hormone, which on this hormone cascade, whatever controls our blood pressure. Okay, so let's summarize what the function of this juxtaglomerular apparatus. Once again, juxtaglomerular apparatus is all of this. Macula densa, extramesangial, mesangial, and juxtaglomerular cells are the 3 components of the apparatus. Function. The macula densa has osmotic receptors and ion receptors on the surface, and feels the osmotic pressure in the distal tubule and makes a kind of conclusion of that. And this information is passed through the extraglomerular mesangial cells. Maybe sympathetic nerve fibers also influence this system, and it passed over to the juxtaglomerular cells. The real mechanism is not known, but definitely this is the way of the signal conduction. These cells will release hormones, the renin, to the bloodstream, and the rest happens in the blood. The renin makes a complex with an enzyme, the angiotensin convertase enzyme, ACA is the abbreviation of them, which transforms the inactive angiotensinogen, or in some books angiotensin 1, this is produced by the liver, to active angiotensin or angiotensin 2. This angiotensin has 2 actions. Number one, it acts on the adrenal gland and initiate production of aldosterone. Aldosterone acts back to the distal tubule of the kidney. It keeps back more sodium, consequently more water, and increases the blood volume. This is one effect of the renin. The other one, the angiotensin, has a direct action on the smooth muscle of the vessels, makes a kind of mild vasoconstriction, and when all of the arteries has a slightly narrower than earlier, the central blood pressure will increase. So all of them result in an increased blood pressure. Now let's see the fine structure of the tubuli. You know, from the Malpighian corpus school we come the proximal tubules, the Henle's loop, and the distal tubule system. The proximal tubule, which consists of the convoluted or contorted part and the straight part, both of them has the identical histological structure and identical function, so we make no distinction right now. As you remember, this is 60 micrometer in diameter and up to 12 millimeter long. This is an electron microscopic reconstruction of the cell. This is a real electron microscopic picture of that. And this is the light microscopic. You can see light microscopy, you can see washed surface. You cannot really see a surface because the cells have a lot of hairs, microvilli on the surface. As you know, the microvilli is for increasing the surface. Consequently, the bigger surface means that easier passage of, in this case, primarily sodium. These cells have lateral processes, which makes them more larger surface contact with the neighborhood cells. The cells, there's a basal stripe. Basal stripe means that membrane invagination, fold-like membrane invagination are in the bottom, and between these membranes we have a lot of mitochondria, and these are very nicely, regularly located. This is why it looks like stripe. Why we have that? The large number of mitochondria suggests that we have an energy-demanding process taking place, and the big membrane surface tells that this energy-demanding process is something related to membrane transport. And this is really that. This is the mechanism which pumps out from the cell, especially sodium. So the sodium passes through the upper surface passively in the direction of the osmotic pressure, because the sodium concentration can be lower in this cell because it is pumped out on the bottom to the vessels. Additionally, it's interesting that the endoplasmatic reticulum looks like sacs, a saccular endoplasmatic reticulum, which are around the mitochondria and also sometimes around the nucleus. The Henle's loop is a very thin epithel. This is a simple squamous epithel. You can see the lumen of Henle's loop. You can see these cells with a relatively little cytoplasm has not too apparently doesn't look like to be very active. However, it's very strange in simple squamous epithel. They have microvilli on the surface, and this will also facilitate the diffusion through the cells. And this is the function of that was described in the previous lecture. This also have, like all the nice epithels, a basement membrane. The distal convoluted tubules also can be divided into straight and the convoluted part, also identical structure, identical function. The parameters was described before. These cells differ from the proximal ones that they do not have brush border on the surface. Every now and then we have a single hair on that. The function is not known. Probably it's just a kind of developmental mistakes. However, the basal stripe is identical. This is also showing a kind of very active ion transport. Also, some pieces of information was given in the previous lecture. The collective tube is nothing else, just has a similar role as the tubes of the glands. It means that just simple cuboidal epithel, which lets the already ready-made urine to the duct system, so short and narrow. In the medulla, we have the combination of these. We have the tubes of the nephron, so the proximal, distal, and the Henle's loop. Here we have an electron microscopic reconstruction of that. This is practically the Henle's loop and the proximal distal tube. Besides, we have a capillary network. This is one example of the capillary. The specific tubes of the medulla, especially close to the papilla, is the papillary duct. The papillary duct is these upper parts, the small ones, is cuboidal, lower is columnar epitel. And interestingly enough, among the epitel cells, we have some dark cells. Most of them are pale, but some of them are dark. So this is why we have the clear and dark cells. They are slightly distinct. The dark cells have microvilli on the surface, but what's the real function, we just have some guess, but we don't have any definite pieces of information. We have also so-called pleomorph cells, these violet colored cells representing them. This is has a sophisticated surface. And in the cytoplasm, we have lipid droplets. They very probably contain prostaglandins, a kind of control substance. Beside that, we have the usual cells. We have fibrocytes, these green cells representing them. We have pericytes, these pale blue cells are around the capillaries, and we have a couple of lymphocyte-like cells, and that's about it. This was the summary of the fine structure of the kidney. Let's go further on and let's see the structure, histological structure of the urinary duct system. As you know, the urinary duct system starts in the renal sinus, in form of the lesser and greater calyxes and the pelvis. Everything starts with the lesser calyx, into which the tip of the medulla, the papilla, grows in. And here you can see a light microscopic picture with a small magnification. You just only guess or see that on the surface of the papilla we have simple columnar epitel. However, in the opposite surface, it already starts the urothelium, the transitional epithelium, which starts in the fornix of the papilla and goes all the way to the end of the urethra. So here you can see a fornix calycis with a larger magnification. The electron microscopic reconstruction of the lesser calyxes. Lesser calyx has a standard expected mucous membrane. So as I mentioned, the epitel is a transitional epitel. Below that we have a loose connective tissue. And below that we have smooth muscle already, but this is quite rare, not organized. We have a kind of network-like rare smooth muscle. Pelvis has similar structure. The epitel and the underlying connective tissue are identical. And also we have not yet fully organized, but we have smooth muscle present in the wall of the pelvis. The ureter, which leading the urine from the kidney to the urinary bladder, is a little bit more organized. This is a tube with star-like lumen. The epitel is urothel, this transitional epitel, as we expected that. And the lamina propria, as always, is a loose connective tissue. The lamina propria makes folds, and the folds are longitudinal. Do you remember the general rules? That we, in the tube-like structure, we have two types of folds. Can be longitudinal. In this case, the lumen of the tube is star-like, and can be transverse, like in the gut. On those tubes in which the content should pass as quick as possible, like esophagus or in this case the ureter, the folds are longitudinal. When it's shrunken, the lumen almost disappears. On those organs in which the content should stay as long as possible for digestion, like in the gut, we have transverse folds in which the food has difficulties to get through. Which way the fold goes is divided by the next muscle layer. So if we have longitudinal fold, the next muscle layer, in which case the inner layer of the muscular layer is longitudinal. All the other inner cuts, this is why they're circular. So we have that. The muscular tunica musculosa has 3 layers. It's not really strong, but identifiable. We have an internal longitudinal, a middle circular, and a very scarce outer longitudinal. Important thing is it's very extensible. You know, the ureter, the transparent penis, already can tolerate stretching. The loose connective tissue is especially loose here, so very high ground substance content. And the muscle, of course, they are extensible. So whenever we have pressure in the urination, it can enlarge at very large quantities. Okay, so this was about the histology of the upper urinary tract and the kidney before. Now let's spend a few words on the development of the kidney. Interestingly enough, the students afraid of the development of the kidney. But if you think it once over, it's not that complicated. To understand that, I will conduct back you to the early embryonic development. You can see this is the embryonic disc with a just made 3 germ layers, the ectoderm, the mesoderm, and endoderm. Here, you remember, we have the amniotic cavity and down the yolk sac. Whenever the mesoderm starts differentiating, it will divide into 3 components beside the axial mesoderm. This is the paraxial mesoderm or somites. This is the gononephron and the lateral plate. The kidney develops from the intermediate mesoderm, also named gononephron. The gononephron along the embryo is differentiated into various segments. First of all along we have a tube made of that tissue. This is what we name the Wolffian tube, and the rest of the tissues has different fates. In the upper area, in the cervical and upper thoracic area, we have the pronephros, in which a very interesting thing happens. At that level, the aorta makes glomerular tufts, and it goes into the lateral mesoderm, and it will filtrate, I would say, urine into the coelom. And at that level of pronephros, the Wolffian duct make tubes which picks up the urine from the coelom and collects away. This is the permanent kidney of the amphibians, like the frog. And as you know, during ontogeny, whenever in embryonic life, in the intrauterine life, we go all through the phylogeny of the mammalians, and for a few days, once again, few days, we have similar kidney, but later it very soon disappears, and the pronephros disappears completely. Not even medical problem remains on that. It's just history. The mesonephros is a little bit more complex. In this case, the vascular tufts doesn't go to the coelom, but it makes connections with the Wolffian duct. The Wolffian ducts grow as outside tubes, which do not grow in the direction of the coelom, as in the pronephros, but in the opposite direction, and makes contact with the capillary loop. This looks like nephron, but this is still not the kidney, because this is the kidney of the reptiles. This one we can just a very small number, relatively small number of nephrons, and this also disappears. The capillary tuft and the end of the tubes disappears completely. The part of the Wolffian duct and these tubes will also disappear in females. In males, this tube and the Wolffian tube remains, and this will be the ducts for the testis, ductuli efferentes testis and the vas deferens. The third part of the gononephron, the lower lumbal and sacral part, will not make any kind of such a tube or such a nephrons, but remains as a single group of epithelized cells. This is what we name metanephrogenic blastema. This will communicate with the other part of the gononephron, the Wolffian tube, and a little side tube glows into this tissue mass. This is what we name ureteric bud. And from these 2 types of tissue will be our kidney development. So once again, at the beginning, homogeneous epithel-like mass. This is the metanephrogenic blastema, and a side tube of the Wolffian duct, the ureteric bud. This is a derivative of the Wolffian tube, in which also in ladies are permanent. At the next step, this ureteric bud give off branches, and the total, it's very rich branch system, total of 1.5 million branch will be, that many, as many glomerulus we have. Meanwhile, and that's the key things, and this is a key word if you want to pass the exam, the renal vesicles are formed from the mesentery. What does it do? What does it mean? With apoptosis, this is what I said before, apoptosis, cells die, and they make a cavity, and this is what we name renal vesicle. And in the wall of this cavity will be the major parts of the nephron develop. How? This is what you saw in the previous picture. Then this renal vesicle and the ureteric bud will make a nephron. If you see a single vesicle become enlarged, and one end make a contact with a capillary tuft coming out of the artery. Then the other end meets one of the end of the many branches of the ureteric blood, and this will communicate. Finally, it's not really difficult to imagine from that. This will be this area, the vascular end, will be differentiated as the Malpighian corpuscle. The vessels is the glomerulus. The rest of them grow a little bit, forming the tube of the nephron, and this nephron will open into the end of the collecting tube and let the urine conducted away. This is the most crucial step of the development of the kidney. 1.5 million times must these two tubes meet each other and communicate with each other just to let the urine develop. Now I prepared a little animation on that. You can see this is the renal vesicle. It's enlarged. One end makes communication with the arteries, the other one open together and let the urine pass through it. Let's try to see again. I hope it will start again. Yes, so this is the apoptosis renal vesicle, enlarged as a tube. One end will make contact with the vessels, the other end will open into each other, and this is how the nephrons made. Once again, this happens in the kidney about approximately 1.5 million times, so this requires a very delicate and precise organizing work. As I mentioned, all of this kidney develops in the pelvis, in the sacral region. So the next step, the last step of the kidney development is the kidney must migrate up to the position on the lumbar region. So from the pelvis it goes up to the upper reproperitoneal region. This animation shows it goes up. You can see many branches of the aorta it makes. So usually it's on the way. It picks up branches during the way and loses branches. This will be important to understanding a minor developmental malformation. This structure, which goes down at the same time as the up, once again, whatever goes down are the gonads, and whatever goes down up the kidney, and it will meet the suprarenal gland, and this will be that. So this is the short story of the development of the kidney. The last topic we have to talk about, the malformation. As it said, if anything can go wrong, it will go wrong, and including the development of the kidney. Let's see what type of malformation, which way the kidney development can go wrong. Agenesia is the very first one. This word simply means that not even the traces of organ. So the body simply forget to develop any kind of a kidney. This can be unilateral and bilateral because we have two kidneys. If it's unilateral, one of the kidney forgets to start developing, the other one develops well, there is no problem. Usually it becomes unnoticed because if one of the paired organ develops, usually it can fulfill all the function of the pair of the organs, and there is no visible symptoms. Only problem is that if you are a doctor and you diagnose that the kidney has a very bad, And when you remove the kidney, you have to check whether the other kidneys exist. Sometimes it happened that it was not checked, and they practically killed the patient. Otherwise, no problem. The abnormal ureter is the other one. You remember that the ureteric bud divided normally in the renal parenchyma in the metanephrogenic barastema into many, many branches. Sometimes it's very busybody, and it divides even before it's entering the kidney, and this is what we named the ureter duplex, the double ureter. It functions properly, has no medical problems, just a kind of by diagnosis is. A little bit more problematic, the ectopic ureter. The ureter is normally opens into the urinary bladder, but because the urinary bladder, in this, especially in females, the vestibulum vagina and the vagina develops from the same tissue as the urogenital sinus, and uneven growing, uneven multiplying the cells, this point, which is normally in the urinary bladder, can be in neighborhood area, in other derivatives of the urogenital sinus, can open into the urethra, can open into the vestibulum vagina and the vagina itself. In the babies, it means no problem, because the babies are always wet, especially the girls, and this become unnoticed, that the urine is continuously flowing. Whenever we want to make a kind of training the students to a pot, the children to a pot, in this case, can be a problem, because you cannot control the urinary flow, because the urinary bladder doesn't function. That's very important thing, is not to torture the child, that you must use this pot and so on, because it's unable to do that. Consequently, you have to show to a pediatrician, a clever pediatrician, and this can be solved relatively easily as a standard way. They cut the ureter, put here, they make an appropriate fold there, which it makes a completely correct position, and you save the it makes much easier the life of the patient. So this is a standard, really not problematic operation. Otherwise, the misposition, as you know, the kidney starts developing in the pelvis and migrating up, and during this migration can severe problems. Number one, the kidney is lazy and is not on the original place, somewhere in between, it's stopped in between the pelvis and the original position. This is what we named Ren migrans, and this is also usually have no problem with that, just a kind of by diagnostic value. The Ren-arcuatus, the arch-right kidney, means that the two kidneys somehow connected to each other and make a horseshoe-shaped kidney. And this horseshoe-shaped kidney, whenever going down, will be stuck in the inferior mesenteric artery. They can never go up, motor up, just the inlet of the pelvis. Because of the position, the ureter will be broken, the way of the ureter. It might have problem in the urine, emptying the urine. Interestingly enough, the symptoms by means of which the patient go to the doctor is the very sudden charges of high blood pressure. You know, the blood pressure is mostly controlled by the kidney, and because of the insufficient discharge of the flowing of the urine can cause that. This can be also easily solved by surgery. The structural malformations, so the kidney is okay, kidney is in an appropriate place, kidney is developed, but has some problems with the structure. One of them is the Ren lobatus, the lobal kidney, and the embryonic life it looks like that, and later on becomes smooth. In some people it's forgets to be smooth and have that kind of rough surface kidney. Absolutely no problem with that. This is a kind of just by diagnostic value. So if your patient complaining about, oh, I have a very ugly kidney, the surface of it is very bumpy, you can say, do not show to anyone. Otherwise, yes, no problem. The other thing is, as I mentioned, whenever the kidney is migrating upwards along the artery, it will not pull the artery unlike, for instance, the diaphragm, but it makes new and new connections and losing the lower one. It's like the big worm with 100-foot worm, insect which loses the leg and makes a new one. Usually we have only one, but we can have many arteries or just one or two arteries to different types. So we have many different types of variations of the surface arteries. Also, no functional significance. If a patient has something like this, the kidney is full of functioning, no possibility of health or probability of any kind of kidney disease. The only, which is real problematic, and this is the main reason why we study the development of the kidney, is the so-called polycystic kidney. As I mentioned, the most crucial step of the kidney development is that these two tubes, which develop from two different tissue mass, the metanephrogenic blastema, the renal vesicle, and the Wolffian tube, the ureteric blood, must meet each other. And this meeting should be complete in that many times as many nephron sites, about average 1.5 million. If this meeting doesn't happen, then it starts producing the filtrate or the urine, and this blow up the whole system because the urine simply cannot go out, and it make a cyst. Depending on how many cysts are, the symptoms are different. If you have 1, 2, or 3 such a cyst in the entire kidney, it means 1, 2, or 3 times in a 1.5 million, then you have cysts in the kidney, and practically this doesn't have any problem. When we have about a dozen or close to 100, it means that they start growing. And the problem is not that we lose about 100 nephrons, but the problem is that they compress and stop functioning the neighborhood nephrons. This is why, step by step, the function of the kidney will be minimized, damaged, and the kidney stops working. If we have many such cysts, thousands, in this case the kidney is killed soon in a 1 or 2 years old child. If it has just less number, it can be first noticed at age of 30, 50 years. This preparation was a kidney of about, you can see about 5 kilogram kidney, and taken off of one of our collaborators with the anatomy department. And this cannot be cured anyway, just replacing the kidney with kidney transport. Actually, this is what I wanted to talk about on the kidney and kidney development. Thank you very much for your attention.